AMD A to OCT to RI to Z. Looks like it says we're live now, so just do that again for everyone. Welcome, everyone. We're to AMD A to OCT to RI to Z. I'm going to give people a few minutes to get logged in here. Looks like we're down a few numbers here, Joe. So I'm not sure. You're a music guy. If you want to sing or play the piano for us until people get logged on, the numbers are going up. That's good to see. And we have a special treat for tonight. We have Dr. Zarenko with us. So.
Hello.
And she'll be doing a presentation prior, a brief presentation prior to our actual CE event.
So, Vicki, do you have your slides ready to be shared there for everyone? You don't have to share. You don't have to share them yet. Just as long as you're ready there, because it looks like they're rolling in nicely, and I don't want to go too long here. So. All right, let me, I'm not going to put my slides live. I think you guys can kind of see them there. And I'm going to just, just say you're at the right spot, AMD, A to OCT to RI. I'm going to just click down to this one here. And we have a special treat tonight. We have Vicki Zarenko from Maculogics with us. And she has a brief presentation, about a 10-minute talk on to change the future for your patients, for your practice, and for the profession. This is sponsored here. This is not part of the CE program. We'll let you know when that starts. So this is only about a 10-minute presentation that Vicki's going to do. I think it's going to be an eye-opener for everyone. This is some really good technology. Vicki, thank you for being here. Vicki Zarenko, OD, MBA, FAAO, but I get to claim, as Joe was a teacher for 28 years, I get to claim that Vicki was a student of mine.
I was.
And, she was one of the best that's out there. And she is now the Director of Professional Relations for Maculogics. On the screen right now is her email address. Vicki, that's about all I got for you. If you want to take it over and go from there, that would be great. Go ahead and share your screen.
I will. Thank you. Just give me 1 second. Let's get everything up here. All right. So like Greg said, I am the Director of Professional Relations for Maculogics. And I really appreciate the opportunity to have a few minutes to speak to everybody here. And our goal at Maculogics is really to, like we say, change the future. And we want to eliminate blindness caused by AMD. And we believe to do that, we need to provide eye care professionals with the right kind of technology, the technology to find AMD as early as possible, and then to monitor it even better than we do now, and so that we can intervene early and get to patients before they have experienced vision loss. So I'm going to just very briefly go into the science behind dark adaptation because this is not new science. This is decades of research that has taken the anatomy and physiology in the eye and connected it to the visual function, and has really created a very elegant story about AMD. But it does require us to think about AMD a lot differently than the way we learn it in school. So really, AMD, if you leave here with anything tonight, AMD is not drusen. Drusen happens well into the process. But long before we see drusen, there's a buildup of cholesterol under the retina. And what that does is it causes the blockage of nutrients. And nutrients from the choriocapillaris into the RPE, glucose and oxygen, and in particular, vitamin A. And when you decrease vitamin A, and via this cycle, it actually has a very profound effect on the rods, and it slows them down. It slows down the visual cycle. The kicker to this, though, is that all this time that all of this disease is happening, when we look in the eye, everything looks great. We tell the patients, "Your retina looks great. There's nothing going on." But really, there's a lot going on under the surface. So it's not until enough of this cholesterol builds up and forms a drusen that we can actually say, "Oh, hey, you have macular degeneration." But by the time we're saying that to patients, we're really just seeing the tip of an iceberg. And, with our current technology, OCT and fundus photography and retinal evaluation, we can't see these changes. But when we do dark adaptation testing, we can actually find it through the dysfunction that's going on in the retina. The pivotal study on this was the All-Star study out of the University of Alabama. And what they did was they took over 300 patients and their retinas were normal, and they tested their dark adaptation. And the first thing that was really sort of eye-opening was that about a quarter of them actually failed the dark adaptation test, meaning they had impaired dark adaptation. Again, normal retinas, but there was a visual dysfunction that was going on. We can't measure it with our Snellen visual acuity chart. We can't measure it with contrast sensitivity. We can't measure it with a visual field, but we can measure it with a dark adaptometer. And then what they found was when they followed these patients over 3 years, patients who had impaired dark adaptation at the onset of the study were twice as likely to have AMD after 3 years. And those with dark adaptation that was impaired the most at baseline actually had worse AMD. So not only does dark adaptation testing help you find AMD, but it does correlate with the worse impairment to worse AMD. And the AdaptDX, like I said, measuring dark adaptation was really difficult. The older devices were very, they required a dark room. They required a very skilled technician. They could take 90 minutes to do. It just really wasn't, clinically applicable. So the AdaptDX, the original tabletop unit that came out in 2014, brought dark adaptation testing to our clinics. And the great thing about it is that when you do this test and when a patient has impaired dark adaptation, you can tell them with 90% sensitivity, 90% sensitivity or specificity, and 90% accuracy that they have AMD. So it's really a test that you can rely on, and it gives you another piece of the puzzle of AMD, much the same way that we use visual fields and OCT to give us the whole picture for patients with glaucoma. Now we can get the whole picture for our patients with AMD. And dark adaptation testing, particularly in finding early AMD, is the most sensitive, more sensitive to contrast sensitivity than visual fields, and also very much more sensitive than visual acuity. And you know that early in AMD, even into the intermediate stages, visual acuity doesn't tend to change very quickly, if at all. And while dark adaptation changes 1 year, 2 years, 3 years, even 4 years during the earliest stages of AMD. So it's really, again, this other way to follow our AMD patients and to truly see who is progressing and who is not. So, like I said at the beginning, we have to stop thinking about AMD as just drusen. We use things like the Beckman classification to try to figure out the risk that our patients have of moving into the advanced AMD stages, but it's only part of the story. Now with dark adaptation testing, we can find it even before we see retinal changes, but then follow it all the way through so we can identify those patients who are faster progressors or who are at more risk of advanced AMD. So hopefully now you can see, because AMD at its earliest stages through intermediate is just all the same disease. It's just how much of that cholesterol has built up. So every stage of AMD is AMD. And the earliest clinical sign is not blurred vision or a dark spot in the vision, but delayed dark adaptation. And then the earliest symptom is not, again, blurred vision, it's I'm having trouble seeing at night. So I want to just take a couple of minutes to talk to you about the AdaptDX Pro guided by Thea. Our original device was a tabletop device that required a dark room and a technician. But now with the AdaptDX Pro, you can do dark adaptation anytime, anywhere. Your technician can do the other things that they need to do while the test is running. And your results are going to be very consistent because Thea actually walks your patient through the test. So Greg, if you can play the video.
Are you ready to change the future of your practice and improve outcomes for your patients with AMD? Then meet the Adapt DX Pro from Maculogics. Built from the ground up, this custom-designed headset will revolutionize the way you detect and manage age-related macular degeneration. With advanced technology and built-in artificial intelligence, this state-of-the-art medical device accurately and efficiently measures dark adaptation function, the earliest biomarker for AMD. Every single one of the 172 custom parts were designed to capture accurate results while improving patient comfort. The Adapt DX Pro features artificial intelligence in an onboard technician named Thea.
Hello, I'd like to introduce myself. My name is Thea, and I will be guiding you through today's test.
Thea reduces the burden on your technicians and delivers a consistent, accurate testing experience. Advanced precision technology automatically aligns with the eye and tracks the pupil in real time to capture an accurate measurement of dark adaptation function. Light sealing eye cups eliminate the need for a dedicated darkroom, so patients can take the test in any light. Single-use comfort guards provide a hygienic barrier for each patient. A padded liner and adjustable strap were designed for patient comfort. The headset is easy to put on and take off, but remains stable as the patient moves. And an interactive LCD screen displays simple and clear instructions for the technician, making it easy to start the test and monitor progress. The standalone device operates without the need for an external computer. Adapt DX Pro with Thea helps you identify and monitor AMD patients with confidence and ease. Now, high-tech innovation meets high-touch patient care. We invite you to change the future with Adapt DX Pro.
All right, Vicki, very good. Go ahead and restart your slides and
Okay.
pick up right where you were. There you go. Perfect.
So just sort of some housekeeping things. The dark adaptation testing has its own CPT code. It's very well established. National average reimbursement is 6003. And you can co-bill it with OCT, photos, visual fields, and there are multiple ICD-10 codes that you can use for dark adaptation testing. So again, the key is that now we can take a similar approach to our AMD patients that we do with our glaucoma patients. The output of the Adapt DX is a number called the rod intercept, and it's very simple. It's the number of minutes it takes your patients to adjust after a flash of light. And the number to remember in your head is 6.5. If a patient's rod intercept is 6.5 or higher, they have delayed dark adaptation, which again is 90% accurate for age-related macular degeneration. So if a patient comes in and tells you, hey doc, I'm having trouble seeing at night, you do an Adapt DX test and it comes in less than 6.5 minutes. Great, you know, it's not AMD. Let's do these other things like new glasses, might be your cataract, could be dry eye. We'll see you in a year. But if it is 6.5 or greater, now you're going to bring them back in and you're going to do what's called the extended test, which actually tells you exactly how delayed they are. And you use that as your baseline, and then you continue to follow them going forward. And you recommend your treatment, smoking cessation, nutritional supplementation, if you choose, diet, exercise, systemic disease management, and of course, retinal light protection. And then the goal is that you manage them and you make the earliest referral to your retina specialist before they have vision loss. So our goal at Maculogics is to partner with you by giving you the technology that you need to manage AMD. So we bring you the Adapt DX Pro. You can do dark adaptation anywhere, anytime in your office. Artificial intelligence named Thea, who actually gives you a very consistent testing response. And then we didn't talk a lot about it, but My Practice will be coming, and that helps you manage AMD within your practice. So thank you for these few minutes. If you have any questions, you can reach out to me directly, or you can go to maculogics.com and reach out to us through there. And we are more than happy to chat with you. But I appreciate everybody's attention today, and have a great presentation with.
Vicki, before you go,
Yep.
do you want to maybe share a phone number or or some type of contact if they're interested in this type of technology?
Phone number. That's funny because I don't even know if I know our phone number.
Uh-oh.
No, we usually say go to Maculogics.com because you can actually go there, give your information, and somebody will reach out to you because those emails come. Sometimes I get them directly if it's a medical question. So the best way to get in touch with us is actually to go through there because it will get routed either to your RSE, the salesperson. It might go to customer service, or it might even come directly to me, depending on what the question is.
Great, Vicki. Great job. Thank you for being here tonight and being a part of this. Thank you again. It's definitely eye opening, and I'll see if I can take it to the next level when I get into some of the stuff that I'm really talking about here tonight. Joe, any comments for Vicki before we move on?
No, I just want to thank Vicki for coming on and giving us that information. I thought it was very helpful. And with that, we're going to now move into a little bit of housekeeping, and then the continuing education portion of our night.
Okay. Now, did I turn I think my camera was on. Joe, are you seeing webinar housekeeping? Because as you know, I lose everything.
I am.
All right. Perfect. All right. So everyone, we're going to move into some housekeeping here. This course from the beginning has been recorded. A replay will be sent tomorrow to the email that you use to register for this course. Optometric Education Consultants does have a YouTube channel. I do work Monday and Tuesday this week, so probably won't be till Tuesday or Wednesday until I get tonight's recording on our YouTube channel. However, you will get a link tomorrow, about 14 hours from now, that will replay this if you want to watch it. That will come from Webinar Jams. Ours will be on the YouTube channel by the end of the week. We have to abide by all the administrative processes out there, COPE being the biggest one. So please, you'll get an email tonight about 2 hours from now. There's a survey in it. Please complete that. There's a few other questions in there to help Joe and I out. And you'll also get one tomorrow with that link. If you forget to do it tonight, there'll be one tomorrow. Just complete the survey for myself, Joe, and Vanessa. Best thing that you can do right now is decrease your bandwidth at your house. If you're watching a football game on one side of your computer, or someone's streaming a movie, or one of the children, or someone's playing video games in your house, that will compete. If you don't have a strong Wi-Fi, that's when delays can occur. So just kind of cut down on the competing Wi-Fi at your house. Remember this, because this is the big one, right? Everyone wants to get their credit. Vanessa will upload everything to Arbo. I will get her the information tonight or tomorrow. She will get it to Arbo. There's a ton of webinars going on right now. The academy's going on right now. There's tons of stuff being hit to Arbo. They're about a week behind. So give them about a week to see that. Vanessa will also email you a certificate. I know there's some states out there that don't use Arbo, so you'll get kind of a dual process here. Upload it into Arbo, you'll get a CE certificate that's out there. All right, chat questions. I'm going to talk about this here in a second. Oh, I forgot to upload the photos here. I'll try and walk through it. If you're looking at your screen right now, I don't have the pictures in here. My apologies. I had them in here and I didn't save it. If you look at your screen on the right-hand side, there's 3 dots, and it's in a little red box that expands and contracts your screen. That's how you get to the chat, the handouts, the polling questions. If it's on maximum, you can't see anything. You have to hit that and shrink it down, and that's where you'll see the chat, the files, and the polling questions. So please click on that and shrink your screen down so you can see that. We want to do a test polling question here. So, Joe, again, I can't see it. Can you launch the test polling question there, Joe? This is kind of everyone to kind of figure out how to use that little red box. 3 little dots, shrink the screen, expand the screen out.
Here's our test. Where is your practice regarding COVID-19? Is it closed? Is it open only for emergencies and urgencies? Is it open with a reduced schedule? Is it open and back to normal patient count, or are you open and busier than ever before COVID? And this has certainly been changing as our months have gone on. Okay, we're doing great. We don't answer in chat. We answer on the poll. And I'm gonna end the poll, and we're gonna say, for the most part, it's open and back to normal patient count. Some people still have a reduced schedule, and some are actually even open and busier than before COVID.
Great. So that's the polling question. Again, if you're having trouble, use those three little dots, little red box, shrink your screen down, so on and so forth. So Joe, can you do me a favor since you have access? Can you go to the files?
Indeed.
And in the files, there should be a handout. We're going to launch the handout. And if anyone wants these slides, because I'm doing 6 slides per page, if anyone wants my slides full screen, I have no problem. You guys know all about education. I have no problem sharing my slides so that you can see some of the details of what we're going to talk about tonight.
Well,
Is it being shared?
No, I'm going to have to apologize. It looks like it disappeared. It was there. I went to publish, and I think I hit delete, Greg.
Uh-oh.
That was an easy one. I blew it.
All right.
We'll put
Anyone that wants a handout, just please email me, and I'll get you the handout. Yeah, it is right beside each other, delete and share. It's kind of a little quirk of the system. Okay. With that being said, I'm going to move to the next slide, Joe. We got to pause for a few seconds here when we do that.
Welcome to our course tonight. It's entitled AMD A to OCT to RI to Z, What You Need to Know. It's presented by Optometric Education Consultants with Dr. Greg Caldwell as our speaker, and I'm Dr. Joseph Sauka. I'm going to be the moderator. It's my great privilege and pleasure to introduce my partner, Dr. Greg Caldwell, as our speaker, a 1995 graduate of Pennsylvania College of Optometry. He completed a 1-year residency there in ocular disease at the Eye Institute. He's a fellow of the American Academy of Optometry, a diplomat of the American Board of Optometry, and a fellow of the Optometric Glaucoma Society. Currently, he works in Duncansville and Johnstown, Pennsylvania as an ocular disease consultant. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease, and he has been a participant in a number of FDA clinical investigations. He's lectured extensively throughout the country in over 12 countries internationally. In 2010, he served as the president of the Pennsylvania Optometric Association, and he also served on the AOA Board of Trustees from 2013 to 2016. He is currently president of the Blair Clearfield Association for the Blind. I'm going to let Greg take it over here.
Thank you, Joe. And, Joe, it's always great to have you as a partner for this. And thank you for moderating for tonight. When we do these presentations, we have to do disclosures. Obviously, tonight it's macular degeneration. Many products and instruments and companies are going to be discussed. I don't have any financial interest with any of these companies. Joe went through what my organized optometry was. For tonight, you're going to be seeing some OptiView OCTs. You're going to be seeing some Maculogic stuff. Again, I've lectured for them and do dinner programs and so on and so forth. Nothing is being influenced tonight with this program. You can see the advisory boards. I am PA medical director for Involved, which is a managed Medicaid in Pennsylvania. And with that being said, I want to make sure that there was a clear cut out there between the CE and now we are starting the CE program. So we'll make sure that we meet our hour and 40 minutes here. Okay. So the course description objectives, once we get you the handout, you'll have this in your handout, so I will not read this to you. Macular degeneration and its dominance. In 2010, the World Organization estimated 5% of the world's blindness was due to macular degeneration. This is a leading cause of blindness over 55 years in the United States. 11 million people in the United States have macular degeneration, and it is going to double to 22 million by 2050. Approximately 1 in 14 people over age 40 have some degree of macular degeneration. Think about that, 1 in 14. Once we hit 60, 1 in 8. Once we hit 80, 1 in 3, a third of our patients. If you take breast cancer, Parkinson's, and Alzheimer's and put that all together, you still have more macular degeneration cases that's out there. It is the leading cause of blindness and vision loss in Caucasians, and it affects 1 in 5 families. Now, this is hereditary. It's a strong genetic linkage, probably one of the strongest that's out there when you talk to the geneticists that are out there. So let's focus on this here, eye care professionals in the landscape. There are 58,000 eye care professionals, which means there's about 40,000 optometrists, 18,000 ophthalmologists. So there's your 58,000 number, and 10% of those are retinal specialists. You're going to hear me tonight hone in on this is our disease in the early stage. We can be doing a lot for this. So when we talk about macular degeneration, if you look down here with my pointer, Joe, is my pointer showing up there on your end? And I know you're probably on mute, so I'll give you a second to come on.
It is not.
Okay, so you can't see the red little button.
No, I see it.
Okay, so glaucoma is 4.9 million of diabetic retinopathy. Again, macular degeneration is 14 million. I do a lot of diabetic programs in Pennsylvania and for other states, and we're talking about 4.9, and there's 14 million patients with macular degeneration. This over here is pretty interesting here. This is when a patient presents for an anti-VEGF. And you can see 78% of the patients are either legally blind or visually impaired, which means less than 20/50. And when they present, rarely do they have good vision. We can do a lot better, and that's the whole point. There was a pretty neat study out there that's kind of circulating and keeps getting talked about. This was primary eye care physicians missing visible disease in 25% of the patients. This was 1,288 eyes, 644 people. The mean age was about 69. There were more females than males in this study. But the key here is 25% of normal patients had findings consistent with macular degeneration. 30% of them of missed AMD eyes had large drusen. Keep that in mind, because I'm going to kind of help you out with that here in a second when we talk about intermediate macular degeneration. And this is a well-known risk factor for the progression of to go to advanced disease. Now, I do a lot of organized optometry stuff. You know, ODs, MDs, always kind of battling for that turf. ODs and MDs missed AMD diagnosis equally. So there's nothing out there between OD and MD. When it came to this study, it was equally missed. But the kicker to this whole study was that doctors were aware that they were recruiting for patients. AMD were looking for drusen, and it was actually being missed. So kind of go back and make sure, you double check these patients that are out there. Some considerations and pearls for macular degeneration. There is currently no cure. We know that. But proper detection, you're going to see me hone in on that. And I got a couple of examples here. Proper detection in eye care prevents significant visual acuity loss in many patients. Is or are anti-VEG injections for our patients the best hope? Meaning, we're monitoring, and I'm going to try and teach you what to look for and monitor in your OCTs tonight. And maybe some new technology in OCTA. We're going to talk about dark adaptation here, where it's really critical in these early stages. Late stage treatments, albeit necessary, doing these injections have little impact on central acuity. We could be doing better, impacting and intervening from early to intermediate. We could be doing better, and I hope I can convince you tonight. We need to rethink our responsibility, meaning optometrists. We need to rethink our responsibility when treating macular degeneration, the diagnosis and management. Commit to what we can do better, meaning early detection and treatment. And I hope I can bring that on to bring a little life to that. No, execute and employ treatment, clinically appropriate clinical guidelines. So we want to take these clinical guidelines, develop your own. I'm going to try and help you out tonight. Develop your own clinical guidelines, know them, and execute, employ them. I think you'll see that we can do a lot with these patients that are out there. Just have to know what we're looking for, and that's why we're taking this course tonight. We want to preserve the vision. We don't want to wait until vision has been lost. Closely monitor, treat, early detection. You're going to hear me. You're going to hear me keep saying that over and over again. You're going to be like, Doc, please move on. Get off of that soapbox. So here's how the soapbox starts. So here's Chad from ODs on Facebook, and he puts a loss of foveal pit with macular traction and drusen appearance, which may be vitelliform, And Amsler grid is normal in both eyes, 20/25, 20/30 vision, mild cataracts. Who sends this to retina? Who monitors? Chad's reaching out. I know Joe and I both know Alan Glazier well. We help him. We post on his ODs on Facebook. So I kind of police this, and this is what I kind of want to show you here tonight, where we want to start. And we're going to point out with these two drusen here. Obviously, there's an epiretinal membrane. There's an epiretinal membrane here, and again, drusen. And as I look down through here, he's asking for an opinion. Who sends the retina? Who monitor? So everyone's monitor, monitor, monitor. What is retina going to do? Monitor, so on and so forth. Over here, this is not animated. This person here got really creative, and this was kind of rotating as a GIF, GIF. It was rotating as a computer monitor to show his to monitor. And you're going to see my reply here towards the end of what I thought that we could do for this patient other than just monitor. All right, so that's kind of teeing it up that we as optometrists can do then more than just monitor. So early onset of pathogenesis. Drusen, small or large, are not markers for early macular degeneration. There's visible structural evidence of the pathogenesis process underway for quite some time. If you guys think about it, remember we all went to school, us older docs, when we were looking at neuroretinal rim, we didn't have GCC. We didn't have nerve fiber layer. We were relying on photos, which are still important today, Drans hemorrhages and visual field defects. Now we use, things like GCC and nerve fiber layer. So there are cholesterol deposits underneath the surface before the drusen forms. That's the key. They're forming in Brooks membrane and building up and creating this oxidative stress, getting bigger and bigger over time to where they then form a visible drusen that we see either in the retina, on the retina exam, either a photo or with your OCT. But we know it just didn't pop out. There's probably something happening before that, and that's the early onset that's out there. This cholesterol accumulates and unfolds and compromises the outer retina. It creates inflammation, oxidative stress, right? That's those free radicals formation. People are losing electrons, or cells are losing electrons. Disruption of oxygen and nutrients, and then you get that drusen formation. If we could pick up like GCC or nerve fiber layer, wouldn't that be cool? And start treating these patients earlier. And so what we know, and it's been proven, and it's not a new technology, it just hasn't been an easy technology until recently, impaired vitamin A crossing Brooks membrane. So if we think about the choriocapillaris, or the choroid and choriocapillaris, Brooks membrane and the outer retina, when cholesterol builds up in there, it starts impairing vitamin A from crossing over. That vitamin A is just really simple. Let's not get into the weeds of this. Just starts decreasing our dark adaptation. So let me show you a few slides here. This is the RPE, and this is the photoreceptors. This red line right here is going to represent Brooks membrane. Down here is choriocapillaris. And this is what we would expect in a healthy choriocapillaris, Brooks, RP, and photoreceptors. Now, what's happening before the drusen formation, and this is so tiny, even though our OCT spatial domain, getting down to 5 and 6 microns of resolution, what is that? If you take a millimeter and cut it 1,000 times and took 5 or 6 of those slices, that's pretty tiny, but even our OCTs cannot see this cholesterol building up into Brooks membrane. So we need to have a test that's out there that can do that. And that test, as I'm going to let the cat out of the bag right now, is dark adaptation. This is where dark adaptation works with macular degeneration. As this builds up, it creates more oxidative stress. The RPE secretes even more cholesterol. And then that leads to oxygen impairment and so on and so forth. And then what happens is now the drusen formation. This is what we now see on a retina exam, a photo, or even on our OCT. But I'm going to click back just because I think this is important. Look at what's happening before all that. Remember GCC, neurofibrillary dropout before we see that notch, before we see that visual field defect. There's the drusen formation. And then that's what we're seeing in the fundus photos. Now we're starting to see those drusen. As we see that, we all know, if we think about, we know that there's something happening before that, before those drusen form. Isn't it really cool, potentially, if we can detect that? So AMD is a disease process that starts below the surface. There's that cholesterol formation, forming and putting stress on that RPE, drusen formation, and then more oxidative stress, more stress leading to choroidal neovascular membranes. So, Joe, we're going to have our first polling question for tonight.
Yes, we are.
And go ahead and get it up. And I actually embedded them into tonight. So I can put out there, as you guys remember now, the 3 dots. If you hit it, it shrinks the screen down. Go to poll, and you'll be able to see this polling question that Dr. Salka is going to launch. And it should say, the best way to diagnose subclinical or substructural drusen is, ? A, visual field or threshold visual field, ocular coherence tomography, OCT, macular pigment optical density, MPOD, or dark adaptation. And now, Joe, what I can't see are the results. So you have to give it some time, and then you let me know what's going on.
Results are overwhelmingly positive in the 90% range for dark adaptation.
Good. So everyone's been paying attention so far. I'm going to, as they're rolling in, go ahead.
Before you go any further, I want to say that I think I'm going to partially redeem myself with Vanessa's help. I have pulled up the handout, and I have shared it under files, so you can now download it.
Woohoo! Files is where it is, and underneath the files is where the handout is being shared. Thanks, Joe. Thanks, Vanessa. So dark adaptation is the answer. I'm going to talk briefly about the MPOD, or macular pigment optical density. That is a risk factor. If someone's MPOD is down, it is not. It could be a couple things. It could be from macular degeneration. It could just be that Dr. Caldwell just likes eating at McDonald's and just has a poor diet. But dark adaptation, as you'll see here, has in the 90% sensitivity and specificity that's out there. So a lot of people get confused with MPOD. MPOD can be low in macular degeneration as a risk factor. It just doesn't mean that you have that subclinical drusen that's building up. It could be, but it's not that high sensitivity or specificity. So when you're staging drusen, this is pretty cool. This is kind of a new, you're going to hear a couple new things tonight. Subclinical or substructural drusen, or what we call the cholesterol layer. And you need a functional test to be able to do that. We all kind of know the Beckman classification, where there's drusen less than 63 microns. There's drusen that are medium, that are 63 to 125 microns. And then you have that large drusen at 125 microns or larger. Kind of look at this. Look at these sizes, 63 to 125, and anything greater than 125. And then we kind of have this new kind of nomenclature out there, subclinical or substructural drusen, because we now have a way of testing for it. It's been there for a while. We just didn't have an easy way of testing for it. So here's the Beckman Committee classification of macular degeneration. So based on the presence of the lesions within 2 disc diameters of the fovea in either eye, no macular degeneration was if you had none or a few drusen 63 microns. You're going to see here pigmentary changes are important. So no pigmentary changes, a few small drusen, you can call that no macular degeneration. Early AMD was medium drusen, 63 microns to 125 microns, and again, no pigmentary changes. Really simple. Once you get into pigmentary changes, pigmentary migration, RPE clumping, that's intermediate. Or if you have one drusen, remember, in 2 disc diameters, one drusen, one within that is 125 microns, or any pigmentary changes, that's considered intermediate drusen, which is now moving you in the risk of moving into advanced AMD. which would be, in this case, a choroidal neovascular membrane is our biggest concern. So you can use your instruments to measure drusen. This is an OCT here that I'm using in the practice. Here's a patient that came into the practice. Everything looks normal, but if you look through their retina, you can see right here, there's a drusen. Here's another drusen. And after you do this for a while and you measure them, just measure 10 in a day or measure them every day for a week, you'll get good at basically approximating the drusen. This is a small drusen. This is a small drusen. You can see here how I've turned on the functionality of the OCT to be able to measure it. And it's this one measured to be 65 microns. So that would be a medium, but you're trying to see what I'm doing here. This would be maybe in a potential to be a small one at 63 microns. So here's another one right here. You can see a little bit of a vitreomacular adhesion, but you can see there's a bunch of drusen as we go across here as I'm pointing them out, but I did measure this one at 123. So this would be a medium drusen. We'll come back to this at some point. This is pigmentary migration. So that would be right off the bat, boom, that would be a intermediate. But just for the sense of this discussion, I'm trying to show you what a small drusen would look like. This is what an intermediate or a medium drusen would look like. And then right here, look at this one here, 461. And you can come over here to the photo and you can see what's happening over here with the photo. You could see this 461. That is one large drusen, 125 microns. I don't really see much pigmentary changes going on, not a lot of pigmentary changes going on. That's intermediate. That's on its way to advanced macular degeneration. We could be doing a lot for this patient, which I'll talk about. Here's some pigmentary migration right here. We're going to talk about that shortly when we talk about progression in the OCT. So as a reminder, choroidal neovascular membranes, there's 4 types. Type 1 is occult. We'll talk about that here shortly. Type 2 is classic. Type 3 is RAP. And I'll explain what RAP is an acronym for. And then we have type 4, which is mixed, which is above the RP and below, which is an occult and classic choroidal neovascular membrane. Here's what I want to spend a little time on. A lot of people buy these expensive OCT instruments. Here are progressions to advancing disease. And we're going to home in on these a little bit better, but I'm going to read them off to you right now. Hyperreflective foci, reticular pseudodrusen, nascent geographic atrophy, sub-RPE reflective columns, drusen substructures, and drusen load, which means they're there and then they disappear, regression. So drusen load and regression. Then over here, vision loss from geographic or exudative exudative choroidal neovascular membrane. I'm going to try and hone in on these a little bit later to try and show you what to look for on your OCT so that you can take this to the next level in your practice and hopefully be able to pick up progression and maybe treat these patients a little bit more aggressively in your practice and slow down this disease. I get it. It's genetics. If someone comes in and they are programmed to lose their vision at 65 or 70, we can do things, change their diet, have them wear sunglasses, exercise, get them on some type of vitamins. They were programmed to be 70, maybe even get them to 80. That's 10 years of good vision. When we all like to have 10 years of good vision, if we're genetically programmed to have this happen, we can do that. We just need to be able to treat it aggressively. And that's why you'll see me being excited tonight about this. Tools for diagnosis, management and treatment of macular degeneration. Comprehensive eye exam. The comprehensive eye exam looks for structural changes and some functional. Fundus photography or fundus autofluorescence. That's structural. OCT and OCT angiography, structural. So check this out. Structural, some functional, structural. Dark adaptation is the only functional that's out there. And then how about the pigment density testing? We chatted about that already. That gets confusing out there. Again, MPOD could be low for many reasons. Dark adaptation, we're going to talk about that here shortly. If it's compromised, as long as the patient doesn't have liver disease, known vitamin A deficiency, meaning liver cancer or liver failure, because that's where vitamin A is stored and released, or maybe even retinitis pigmentosa, which you'll be able to see on a dilated fundus exam. If they fail on dark adaptation, it's a 91% sensitivity, meaning true positives. Or if they pass, that's the specificity, true negatives, says that they don't. So if you have someone that comes in with a negative, or if the family history of a macular degeneration, you run this test and they pass, that's at 6.5 minute, which we'll talk about. And they pass, that's what 90% that, hey, right now you're doing pretty well. We can watch you in a year. But if they fail, should we be intervening? And hopefully that's what we're going to talk about tonight. So applying a familiar standard of care, you know, you heard me talk about this already with glaucoma. I see that there's a really nice parallel structure. We can use cup to disc ratio. Function is visual field, and risk factors out there, higher IOPs. I have patients with 24, 25, even 28 that I'm not treating. It's just a risk factor. We're following them, waiting for some type of damage in that nerve fiber layer, GCC, visual field, neuroretinal rim, photography, and we're just following. They're ocular hypertensive. Cornea thickness, race, age, family history. Those are all risk factors. Same thing happens on the AMD side. We have structural changes such as drusen. And the function, the parallel there is dark adaptation, visual field, dark adaptation that's out there. And then you have your risk factors, age, genetic testing, smoking. That's a huge risk factor in macular degeneration. And there's where your MPOT or your macular pigmentary optical density comes into play, along with contrast sensitivity. So let's talk a little bit about dark adaptation. And this instrument has been around for a while, and it is able to measure dark adaptation. You know, we always tease that, you know, visual field was punishment, even more visual field, more than visual field punishment was doing this test right here, dark adaptation. I put the person in the room, make sure there was no light coming through, dark adaptate them, put them in the instrument. And it was very sensitive, and it was very specific for those who have the disease and those who don't have the disease. It wasn't an easy test until there was a newer instrument that came out earlier this year. But we're going to talk about dark adaptation. We don't want to talk in a CE program. I just want to lead you that dark adaptation is how you test for early functional AMD. Just right now, the only test that I know of, there's one out there. So, and you guys can do the research on where that is. So dark adaptation measures how long to recover from bright to dark, right? You can kind of do it as, I have some patients that come in, they're like, man, doc, it takes me forever to dark out. How's macular degeneration in here? Yeah, it's strong. You know what? Let's not do that kind of anecdotal test. Let's get you measured and see what happens here and see if we can start intervening for you. And it's a great functional test that overcomes the challenges of diagnosing early macular, or even when patients do have macular degeneration. It's very well studied. The Alabama study on early age-related macular degeneration, even in my home state, Pennsylvania, Hershey Medical Center, they have done lots of testing out there and have validated that you can detect macular degeneration before the drusen 3 years earlier and start intervening with these patients. And it all has to do with that vitamin A not being able to cross that cholesterol barrier, not being allowed to get to the photoreceptors and create that dark adaptation. And if you think about it again, I kind of let the cat out of the bag. What are those diseases out there? Okay, liver failure, vitamin A deficiency. We're probably going to be able to ask the patients if they're having any of that going on. Retinitis pigmentosa, the list isn't long. If the patient is having issues with dark adapting, it is probably from cholesterol building up into that Brooks membrane, impairing that vitamin A. And then with a 91% sensitivity, those with the disease, or 91 specificity, we tested you were below 6.5 minutes, 6.5 minutes. You don't have it, or you've went above it, we better run a longer test on you and figure out what we need to do. And there was all this buzz at the end of 2019 out there. You know, everyone was excited, and that's really where this instrument here, which was the if you wanted to punish your technician, whoever you didn't like, you made them do this test, but now there was a new headset that came out there. And really, you didn't have a dedicated room because these cups seal around the eyes and really puts them in a dark room right there without having to use a big instrument, what I used to call the microwave. So the Adapt DX, it's a handheld controller, rechargeable battery. It's got this UBC cable, and basically this is the instrument that you can test for dark adaptation. So what does this mean? Early symptoms. If you don't have macular degeneration, you can dark adapt pretty easily. Now, someone can say, hey, doc, patients with cataracts have an issue. Right. They have a tough time seeing at night, but they don't have a tough time dark adapting. So if you have someone that's in your practice that has, let's say, a stage 2 cataract and they're having trouble seeing at night, you can run this instrument on them. The cataract's not going to have them any problem. It has no problem with vitamin A deficiency. It doesn't have any problem with dark adaptation. They have problems seeing at night. If you run this test and they fail, you better be doing something for macular degeneration if they have that family history. So people that have no macular degeneration don't really have a problem with dark adapting. It's whenever they have this problem dark adapting that they could have this subclinical, substructural. These are some new terminologies that we're using as lecturers, as in science. Subclinical, substructural drusen, or we're calling it just early AMD, right? Think about glaucoma. Before, when we would see a visual field defect and we would see a nerve fiber layer, we know now that there was nerve fiber layer and GCC loss. We just didn't have the ability to detect it. Now we have the ability to test their dark adaptation, and they now have earlier subclinical AMD. They're just not getting the drusen. So it's this night vision that's impacted in patients with macular degeneration. And again, I can't say it over and over again. A high sensitivity, those with disease, high specificity, those without the disease. So what we've been doing in the practice is patients over 50, we ask them about their night vision, and now we can test it and see how they do. And we can test it very easily with an instrument. So that's kind of dark adaptation out there. Again, look for an instrument that can do that if that sounds like something that's in your practice. Now I kind of want to shift over to what some people have in their practice in OCT. And if you're going to follow macular degeneration, especially looking for these intermediate or worse type of cases, you want to make sure you have a spectral domain. So that means if you're still using a Stratus out there, because that was probably one of the first time domain OCTs out there, time to upgrade to a spatial domain, and you pick whichever company you want that's out there for that. Just do your due diligence. Able to identify OCT or OCT predictors of progression. And here they are. I got them listed for you. Hyperreflective foci, reticular pseudodrusen, nascent geographic atrophy, sub-RPE hyperreflective columns, drusen substructures, and drusen load and regression. When you see this happening on your OCT, the patient is progressing. It's like having to lower an IOP in glaucoma. If you're not doing vitamins, get them on some vitamins. At least the carotenoids, right? Lutein, zeaxanthin. Talk about the AREDS 2, and we know the vitamins that are in that. Get them on some diet and exercise. And I'll talk about diet and exercise here shortly. Put them in the sunglasses. If they're a smoker, have them quit smoking. There's a lot that we can do out there. And when we start talking about OCT, I'm going to narrow down this list for you. There's hyperreflective foci and sub-RPE hyperreflective columns, which are important. So polling question number 2 here, Joe. If you're ready back there, again, remember, you can see it, I can't. The polling question number 2 is, this OCT is showing which predictor of progression? Quite well. Reticular pseudodrusen, nascent geographic atrophy, sub-RPE hyperreflective columns, or drusen load and regression.
Okay, it is up. I think we're seeing it. Remember the 3 dots.
So on the screen, you see a
how-
drusen that's 123 microns. You'll see some RPE changes. Go ahead, Joe. I'm sorry.
Nope, now the poll is working. I'll give it a few more moments.
Sure, absolutely.
And it looks as though the audience has said predominantly drusen load and regression. And behind that is sub-RP hyperreflective columns.
Good. Perfect. So we'll see if that would change here in a second. So I'm going to move on. And I want to talk about hyper versus hyperreflectance in an OCT. When there's hyperreflectance, as in this case here, the RPE, or in this case here, the photoreceptor integrity line, that coherent light is being absorbed very at a high level, and it's hyper-reflecting. As you can see here in the nuclear bodies, there's not much absorbed light, as in this nuclear layer here, or this inner nuclear layer or outer nuclear layer. And you can see that it's black. So that would be hypo versus hyper. So in the case here, this is a blood vessel, and blood vessels have blood in it. So that's a blood vessel that's being absorbing the energy. And you can see down below there's just an echo, for lack of a better term. It's hypofluorescent, but it's more of a blocked signal. So this would be your hypo right here where I'm pointing, where it's black, and this would be hyper where it's white. Now, I'm driving down the road, and this is what I've been kind of waiting for, this picture, and I kind of in the fast middle lane here. I did move over from the fast lane, grabbed my camera, so I wanted to take this because this is pretty important here, picture in my opinion. Nice little cloud bank, but there's a break in the clouds right here, and you can see that there is a cloud or a beam of light, and there's another beam of light, another beam of light right here. Well, for all of you that have flown a lot, it's a cloudy day and you take off and you fly. I mean, you maybe it's even raining, it's dark and dreary, but you get above the cloud banks, hey, it's kind of sunny. Well, we know it's sunny above the clouds, and when there's a cloud bank, if there's a little break, the little ray of light will come through. So we can learn from these pictures. You can see the ray of light here busting through, and the different rays of light. And here was another beautiful picture out where I live. Sun's kind of setting, little break in the clouds, and you can kind of see the sun coming down through here. How's that relevant to macular degeneration and RPE? Well, let's take a look at this here. Here is a picture, and I have this purposely covered. What we're looking over here is we're looking at the RPE. We're looking at the neurosensory retina. When I look at macular degeneration, let me tell you where I like to look. I like to look down here into the choroid because I'm going to show you why. I'm going to remove part of this. Take a look at how this from here over looks different than here. Can you appreciate these columns, these hyper-reflective columns? The reason why that's happening is there must be a break in the RPE. The RPE is breaking down, just like these clouds. Just like these clouds are allowing this sun, this RPE is breaking down, even though it doesn't look broken down. It looks hyper-reflective. But if you learn and interpret and learn how to look at an OCT, you could see these hyper-reflective columns. That's those hyper-reflective columns right there. Now I'm going to remove more of the photo. Take a look what's happening here with this outer nuclear layer, how it dives all the way down. Now we have total atrophy of the RPE. This is geographic atrophy at its best or at its worst, whichever way you want to term it. This is geographic atrophy from here all the way over to right about here. And you can see how much hyper-reflectance is into this choroid. When I study macular degeneration, I like to study the choroid. This is the way it should look over here, ladies and gentlemen. That's why I like looking at the choroid and seeing what's happening. You can see this is sick. Look how sick this is right through here. So this is a good one to learn on. All right, so let's go into case number one of OCT predictors of progression. So when we're looking at the picture, there's lots going on here. We have an angiography. We're looking at an ONFOS. What I just want to go down here is just a traditional B scan that we're looking at. And look at these drusen. Look at the hyperreflective columns. And then right here, look at this little hyperreflective area. I'll move my laser pointer here now. That hyperreflective is a focal pigment. That's that hyperreflective foci that they talk about. That's progression. If that wasn't there 3 months ago, if that wasn't there 6 months ago, this drusen has formed. It's created oxidative stress. It's creating a barrier. And now the RPE is breaking down and creating that RPE clump, that RPE change, that stress, that oxidation. It's trying to repair because all the damage that's going on. If this wasn't here before, then you have progression. Maybe bump up your vitamins, see what they're doing, diet and exercise. I get it. Genetics play a role, but just like glaucoma patients don't always take their drops, macular degeneration patients don't always do what you ask them to do. And you have to see what's going on. You can see some RPE changes going on right in this area. And then look right here. Look at the hyperreflective foci. This is an extremely sick retina moving into advanced macular degeneration at some point, if hopefully not, if the patient is lucky. But they're moving that way based upon what I see here in the predictors of progression. If we turn on the angiography in this case, because this is an angiography, that's what the next slide is here. What we're looking at is the blood flow. And we should have blood flow in the inner retina. We should have blood flow in the outer retina. And I'm going to come back to this one a little bit later just to kind of show you what we're looking at. And this is still case one, predictors of progression. All I'm doing is moving these different cursors down through, checking out what's happening, seeing some hyperreflective foci, but more importantly, the RPE progression, these foci that are out there. This is not good. This patient has a very sick retina, very sick macular degeneration. Sunglasses, vitamins, diet, exercise. Please quit smoking if you're smoking. Smoking creates an oxidative stress, as we all know, that's unbelievable to the whole body and also to the eye. Here's case number 2, OCT predictors of progression. Let's take a look. As I like to look is I like to look down here. Look, ladies and gentlemen out there taking this course, look. Hyperreflective foci, hyperreflective column, not a foci, a column, another column, another column, a little bit of RPE changes. If this didn't look like this 6 months ago, 9 months ago, 12 months ago, they are progressing. And I can tell you, I gave you that list of all those different things that can happen, the indicators of progression. The ones that I find that are the easiest way to predict in the office are these hyperreflective foci and these columns. And that's why I'm going to kind of keep hammering on those as we go through. Check this out. Just a big step back view, nice wide view here. Just look down here. This is where I like to look. You guys can appreciate this. Look, that's that break in that cloud, and that hyperreflective, that coherent light is getting through there. This is a sick retina. If this wasn't there before, look at this big drusen. It's so big that maybe the RPE is sick here, but it's that drusen is so big, not allowing that hyperreflective column. But here we know that there's RPE damage, and here, and here. And then that's what creates that signaling for that choroidal neovascular membrane. This patient needs to be followed closely because they can progress to advance. And we want to catch the advanced early to get them over for their anti-VEGF. So this is someone that I would watch maybe every 3 to 6 months based upon these hyper-reflective columns, these foci that are occurring to their RPE. And this is the same case. This is case number 2. And you can see here just another cut. Look at this hyper-reflective column and the RPE changes in the foci that are occurring. And then this is case 3 here, just another predictor of progression. Just look how large this drusen is very large drusen and another large drusen over here. And you can see the blood flow that's occurring out here in the outer retina with the angiography. This is case 4 here, just kind of showing you this is geographic atrophy. This is nothing more than all geographic atrophy in this area. And you can kind of see here, even on the angiogram, these blood vessels that are lighting up, those are choroidal vessels. That's how much geographic atrophy. But what I wanted to show you was look at the hyperreflective columns. Look at the columns here. There's nothing blocking it. There's no, as you can see here, there is no RPE to block. And you can see hyperreflective. Look at this big area over here. Look at the RPE atrophy, right? This is a very sick type of retina that's out there. This is advanced macular degeneration. You guys getting sick of me pointing this out? Look at this right here. This is a hyperreflective foci. All right, and there's a drusen here. This is a hyporeflective column, but that's just how thick that drusen is. But let's look down through here, and all of a sudden we see these columns. And these columns right here are lighting up. And look down here, the columns. I love studying macular degeneration by looking at the choroid and seeing if these rays of sunlight are coming down. This patient is progressing. And if it didn't look like this, again, 3 months, 6 months, 9 months, 12 months, 18 months ago, they are progressing in their macular degeneration. And we can be doing something for this. So check out this patient number 5. This doesn't look too sick. This doesn't look too bad until we look at the other eye, and we can see now that they do have a choroidal neovascular membrane that has occurred. That's out there. So that is dark adaptation. That is how to use your OCT, which most optometrists have nowadays. When we do our lectures and they raise their hand, about 70-80% of the optometrists have OCTs. Now we're going to move into angiography and OCT angiography. And we have the ability to look for occult and classic choroidal neovascular membranes before they leak. Non-invasive technique. Let me say that over and over again, because every time I do a live technique, every live program, we go out, we're having a break, and people ask me, what are you injecting into the eye or into the arm or into this to do angiography in macular degeneration, this structural test? Nothing, okay? We're injecting nothing. Let me say it again. We're doing nothing when we do OCT angiography. Because this scans at 70,000 scans per second, and if you don't have an OCT that does that, you need one that can do that. You need an OCT that scans at 70,000 scans per second. That's the spatial domain. And when it scans at 70,000 scans per second, and the algorithms that's in the program, what's moving is blood and what's staying still are the structure. So you could pick up these subclinical choroidal neovascular membrane or occult non-exudative choroidal neovascular membranes, meaning that you can pick them up even before the fluorescein angiography. So again, OCT angiography, a new approach, non-invasive, you're injecting nothing. There's nothing that obscures the fluorescein. The image acquisition requires less time than a dye-based. You can literally do it right when you're doing your retina scans, and you reduce the patient's burden from having any of these dyes injected. So let me show you what we're looking at here. We're looking at the ONFOS, the OCTA slabs, and based on retina anatomy. All right. Hey, Joe, pause for 1 second here, and I'll be back.
All right. Now, I'm not entirely sure who out there has OCTA. I've used OCT, used OCTA, and have used fluorescein angiogram. And some people may wonder or question what goes on or what is the difference. The great thing about OCTA is it will cut through and actually show you the vessels. It's a point in time. And as Greg's going to explain, it's based upon movement of the blood and the red blood cells through the vasculature, and we're going to identify the abnormal vasculature. Now, that being said, when we have a fluorescein, it's beneficial in that it will show you change over time and leakage, but once that fluorescein leaks, it's hard to really see, or really hard to find the vessels. So I'm going to turn it back over to Greg.
Thank you. I realized that my computer wasn't plugged in, and I was down to 2%, and we were going to shut down and have a big disaster there. So now we're plugged back in. We're ready to go. So thank you for filibustering there for me, or covering up for me there, Joe. I apologize for that to the audience.
And the computer being unplugged was not what I predicted for your absence.
Yep. So yeah, we almost had a disaster there of shutting my computer down, but we're good. Thanks, everyone. I'm back. All right. So let me just start off here that, again, we're talking about OCT angiography and macular degeneration, the ability to identify occult and classic choroidal neovascular membranes before they leak. Again, non-invasive technique. We're not injecting anything. But what I wanted to cover here was, I lost my pointer. Let me get that back on. Is when you find these occult non-choroidal membranes, there are 15.2 times chance of developing exudative macular degeneration. Again, non-invasive and reduced patient burden. You're able to acquire these in less time than the fluorescein, and we're not injecting anything which puts the patient at risk for an anaphylactic shock. So the on-phos slabs that you'll see with these new types of technology is that you have superficial. Remember, the blood flow of the retina is in the inner retina. Then you get to the outer retina, should be no blood flow. And then you have the deep outer, or the choriocapillaris, which has flow. So I'm going to start down here where I'm pointing. The choriocapillaris should light up red when you start looking at these images, a lot of blood flow. The outer retina is black. There's no blood should be out in that outer retina. It's sandwiched between a high blood flow area up here, the superficial and deep plexus, the choriocapillaris, and there should be no blood flow where the photoreceptors are, so we can have that great acuity. All right, here's what the images look like, and again, you can apply this to just about any type of OCT out there that does angiography. The only thing that I'll tell you as a clinical pearl, just look for, in my opinion, the angiographies that can measure density of the capillaries. That's my clinical pearl that I'll give you when you start looking if you're interested in this technology. So again, the inner retina, superficial is right about here. Then the deep plexus is a little bit deeper. And then you get to the outer retina, no blood flow. And then the choriocapillaris has all the blood flow. So white, black, blood vessels, blood vessels. Polling question number 3, Joe, please.
All right, we'll pull up polling question number 3. And we're going to publish it.
Perfect. So it should be polling question number 3. OCT angiography, or OCT, has allowed us to detect a new finding in macular degeneration. Which would this be? Subclinical drusen, hyperreflective columns, occult, non-exudative choroidal neovascular membrane, or retinal angiomatosis proliferation. So OCTA, what can it find? Subclinical drusen, hyperreflective columns, OCT, non-exudative choroidal neovascular membranes, or RAP, which is retinal hemangiomatosis proliferations.
All right, everybody is responding, Greg. And I'm about to put an end to the poll. I'm going to stop the poll. I think we're slowing down. And the winner,
drum roll,
is occult non-exudative choroidal neovascular membranes.
All right, perfect.
At 64%.
Awesome. So let's talk about that. There's 64% out there. Good job. That's why we do these, for those who, might have been scratching their head a little bit about that. So let's talk about type 1 occult choroidal neovascular membranes. What does that mean? An occult choroidal neovascular membrane means that it's below the RPE, and it could be leaking, but there's two reasons why a fluorescein angiography cannot see an occult choroidal neovascular membrane. And the reason being is, and in this case, if you look right here, nice choroidal neovascular membrane. It's in the choroid. It hasn't broken into the RPE or into the outer retina whatsoever, and it's nowhere even close to this picture of the deep plexus. This is all down a beautiful membrane sitting in the choroid. If you come over here, you wouldn't even probably say that this patient has a choroidal neovascular membrane by looking at this B scan. I'm going to be a geek. Everyone look. Hyperreflective columns. Look at the drusen. You can see what's happening here. Right here is where this choroidal neovascular membrane is. This would not be able to pick up on a fluorescein angiography for two reasons. I held up two fingers, so let me just be four reasons. So let me do it this way. Two reasons. One, it's below the RPE. Fluorescein angiography does not see below the RPE. But another reason is it's not leaking. This one is not leaking. Look, there's no fluid down here. Fluorescein angiography, you need to have fluid. This one right here, this is the new term. You heard me talk about substructural drusen. You heard me talk about a subclinical drusen tonight. That's with dark adaptation. OCT angiography now gives us a new term, occult. It's below the RPE, non-leaking, non-exudative choroidal neovascular membrane. These have been so much fun finding in the office. The new blood vessel develops into the choroid. Here's just another example. Now, this one is not an occult non-exudative, right? Because if you look down here, you could see that it is leaking. This is just a type 1 occult. And what that means, it's below the RPE, above Brooks membrane. So, sorry, I'm pointing at the wrong area. This is the RPE right here. Here's Brooks membrane. It's between the RPE and Brooks membrane. That's where this choroidal neovascular membrane is. And in this case, it's leaking. It's exudative. So let's look at this 72-year-old Hispanic male, 20/30 vision, history of dry macular degeneration. When you look at it, you can see the large drusen, right? This person should be on some type of vitamins, diet, exercise. And I'm going to home in on that towards the end. We all could be doing something for these patients. But you see a little bit of fluid here. Maybe there's fluid, so on and so forth. But I ran the OCT angiography on this patient. And what we were able to detect, and I'm going to give you a little bit of a crash course. This is all normal right here. The RPE should be lighting up with blood. That's where the blood flow is. You should get some activity out here in the inner retina. The outer retina should be relatively quiet. But these drusenoid PEDs are non-vascularized. And when you come over to this one, the concern is why is this drusen filling up with blood activity? This one is not. This one is. That's a concern. And whenever you hone in and use the instrument a little bit closer, look, it's not in the outer retina. So that means it's occult. It's not classic. And look at the nice choroidal neovascular membrane that's being picked up. And it's not really leaking. You might argue that this fluid, right, this could be fluid here. But again, I would classify this as a non-exudative choroidal neovascular membrane. Maybe early exudative now that we have the technology. Now remember, type 1 choroidal neovascular membranes below the RPE, wider than type 2. Avascular zone is usually not involved. So here's your avascular zone, and you can see that the occult membrane below the RPE, and it's very wide, wider than a type 2 or a classic. And you can just see here what it looks like. And the not so obvious ones. How many of you out there would say, come back in 6, 9, 12 months, take your vitamins, so on and so forth. I love running OCT angiography on macular degeneration. Macular degeneration, Up until about 4 years ago, it was so frustrating in the practice. Now with dark adaptation, now with spatial domain OCT and OCT angiography, I'm a geek when it comes to macular degeneration. We could do so much for our patients now and keep their onset, especially those that we know are at risk factors. But take a look at this one. It's not so obvious. Even the hyperreflective and the RPE, all the stuff that I've been harping on. And then I decided to run the angiography. And in studying this all looks normal. This looks normal. This looks normal. The inner retina should have some blood flow. I didn't like this extra activity right here in this area. And when I did the 6x6, I'm like, what's going on here? Technician, can you give me a 3x3? Look at this nice choroidal early occult, right below the RPE, non-exudative. I see no fluid choroidal neovascular membrane that's out there. And I have examples of this. Now, let me tell you a little story about what has happened with my retinologist. And this is what you're going to have to work out with your retinologist. The first 3 that I sent over, the retinologist said, it's 15 times more. We're not sure what to do. Should we inject them? Not to inject them. The first 3 that I sent over, they all bled in less than 3 months. The one was closer to 3 months. One was about 6 weeks. One was about 8 weeks. So less than 3 months, they all bled. So now I kind of have this talk with my patients, and I say, hey, look, drawback is I've got this great technology. We're just not sure what the treatment is. The retinologists are doing studies. Should you inject? Should you not inject? And the 4th one we sent over, I educated the patient. I said, look, I would consider injecting it knowing that you have about 3 months before you do bleed. But that's going to be up to you. Risks, benefits, work with the retinologist. And most of the time when we send them over and we find these occult, non-exudative choroidal neovascular membranes, they're injecting them and we're following them because the last few ones that we've done, they haven't bled. Now, my N is about 15. We'll wait for evidence-based medicine. We'll wait for outcome-based medicine. But you're going to have to talk to your retinologist to decide if you have this technology, what you would do for these patients that's out there. Really exciting stuff, but it's great being a part of the team and having this technology and doing this type of treatment. Let's talk about type 2 classic choroidal neovascular membranes. What does that mean? Remember, occult means it's below the RPE. So here's your choroid. Remember, it breaks through Brooks membrane. If it just is housed between here and the RPE, it's occult. But if it breaks through the RPE, it's now classic. And you're going to now see it over here on the angiography in the choroid, now into the outer retina. Right now you're starting to see it light up, but it's also as big and large enough to be able to pick up in that deep plexus that's out there. So this would be a classic choroidal neovascular membrane. They develop in the choroid, and that's important because when we get to type 3 here, you're going to see that type 3 does not develop in the choroid. Type 1 in the choroid, type 2 in the choroid, new blood vessels develop in the choroid, and they make it above the RPE. And again, you can see here, choroid, and now they're into the outer retina. So that's a type 2. Now, type 2, they end up above the RPE. They're smaller. They're usually now in the avascular zone, and they're very heterogeneous in shape. So here's a 48-year-old man, 2-week history of a dark spot. Remember that dark spot in his vision. I ran this test. Well, it looks like it's leaking. It looks like a choroidal neovascular membrane. Ran the angiography, and check out this nice choroidal neovascular membrane. Here's a fundus photo. Obviously, it's the right eye here. Look at the outer retina and this classic choroidal neovascular membrane it has developed in this 48-year-old man with a dark spot in his vision, able to get over quickly and start the VEGF treatment. Type 1, type 2 start in the choroid. Type 3, I'm going to go through this quickly. Retinal hemangioptosis proliferations. It starts in the retina.
Hey, Greg, can I interrupt you for a second? I don't know if we ever talked about this.
Yeah, go ahead.
Or people ever are aware of it, but classic and occult are actually pretty old terms, and they began on fluorescent angiography. And I'm not sure if we had discussed this or you had ever covered this before.
Yeah, this is very white material, as you'd say. So go right ahead.
Yeah, the classic means on fluorescent, and this was years ago before OCTA, before OCT. Classic means they could identify on angiogram the full extent of the membrane. And occult, they couldn't. They couldn't determine the full extent, and it was because of where it's located. And fluorescein can only get so far. And by the time they're doing fluorescein on these patients or these eyes, they were leaking already, which made identification of the membrane edges even more tenuous. So really, they have taken and reused the classification based upon what we know where it's occurring angiographically. That's just a little history lesson there.
Yeah, that's a great history lesson, because I can tell you when I worked in my OD-MD practice back in the day when I graduated and I started working there in 96 and through 2008, when we'd shoot fluorescein angiographies, they were always talking about how well defined it was. And if it was well defined, that would be your classic, because you're able to see the whole thing, and pretty much just echoing in a sense what you said there. Any other comments, Joe?
No, I may have a comment on wrap when you're done.
Great.
I may not.
All right. And then are there any questions rolling in? We'll take that time here to take a break for me to inhale and exhale. And my computer is building up nice power, so I feel a little bit better now.
I've been actually communicating with some people privately on some other issues. There are a couple of good questions. And this is someone who I know pretty well, Linda. Is it really necessary to recommend UV protection after cataract surgery, since IOLs provide UV protection?
Good question. I don't really have a great answer for that. Joe, you might be able to weigh in. I know that implants have UV protection. Is it 100%? If they have a large pupil, could there be anything sneaking out? I mean, I guess they would get some glare. Most patients as they get older. Is there enough in that implant if it's 100%? Probably the answer would be yes, but I don't know. Let me phone a friend. Joe, what's your thoughts?
I would still probably recommend UV protection. It is part of a standard of a well-made pair of sunglasses or eyeglasses. So I would still recommend it.
So yeah, I'm leaning on that side, but I get the question here: if there's enough UV protection there, do you need it? So thank you for that question, Linda. I'm going to dig in a little bit deeper.
Greg, we're going to go back to dark adaptation. Is it no longer appropriate to think of some reduction in dark adaptation to be a normal part of aging?
So my answer is going to be yes, if you measure it. So with the ability now that we have instruments out there that can measure it, and with all the studies that are out there, if you measure it and it's above 6.5 dark at 6 minutes, 6.5 minutes, right? So let's say that, we're able to do dark adapt within a minute or two when we're younger. And as we get older, it takes 4 minutes. Yeah, there's your aging dark adaptation. It got a little bit longer as we got older. But what happens if you reach the 8-minute, the 7-minute mark? I would now start scratching my head a little bit about why has this patient gotten to 7 or 8 minutes rather than maybe the normal aging from maybe a minute to 4 minutes, or up even to 6.5, it's still considered normal. Once you get above 6.5, then you want to start scratching your head, especially with all the studies. The sensitivity, remember, I always like saying that to remind everyone gets confused on sensitivity and specificity. For me, for years, the sensitivity of it, if it's above 6.5 minutes, it's a very 90 or 91% chance that it's a true positive. So, yes, you will get longer dark adaptation, but if you cross that threshold of 6.5, I would scratch my head a little bit and turn a few more rocks over. Great question.
Interestingly, there is a continuum of normal aging changes, and then there's disease process. And it's not always clear when a patient crosses over from a normal aging change to the disease process. And early AMD, as you point out, is very hard to diagnose. And we may not all agree on it clinically, but now we have the technologies that are showing us a few more things happening. Now, Abraham has a very good question. How does myopic macular degeneration play in age-related macular degeneration?
Yeah, well, that's one of those differentials that's out there, right? So someone that has pathological myopia, and remember, you don't diagnose it with a phoropter. You need to look at the back of the eye, and you see someone that has the hallmark sign. That's a PCO term, Salus University term, the hallmark, and not just specific to PCO, but as we lecture, the hallmark sign is a posterior staphyloma. So, obviously, when you start adding in other diseases to this, it in a sense can start changing up the macular structure and the macular changes. But I'd have to look in to see if dark adaptation would be influenced, because dark adaptation is a rod intercept. The macula in progressive myopathy, myopia is more of a macular disease, and the dark adaptation is checking a little bit more in the periphery, the rod intercept, so that you should be able to stay out of that macular area. Now, the drawback is that a patient can have more, they can have macular degeneration and pathological myopia. So the patients ought to have as many diseases as they want, but remember, we're checking the rod intercept on this patient, which would be more rods than cones in pathological myopia. Good question.
Scott is asking, what is relationship of AMD to elevated cholesterol level, and what type of cholesterol is most at risk?
Yeah, it's another great question that's out there. There are studies out there. Can we use high amounts of statins to clear out this and change the dark adaptation? And there's some loose studies out there showing that the answer is yes, but then you get all the side effects of the statins. However, here's the beauty of this, is that there's no real association for high cholesterol. So someone that's running a high cholesterol doesn't mean it's going to build up into their Brooks membrane and create that. So it's a very poor association, high cholesterol to macular degeneration. Macular degeneration is more of an eye problem that's out there, just like glaucoma is more of an eye problem. I understand that there's some secondary glaucomas. Cataract is more of an eye problem. Ultraviolet, some aging. I get that steroids and trauma can cause cataracts. But macular degeneration, this cholesterol is not, and I'll stress that at this time in 2020, is not associated with high cholesterol. Now, they are doing the reverse. You are correct. This is cholesterol buildup. We realize that. Can we use statins and other cholesterol medicine to maybe help out along with these things that we're going to talk about? And the answer is stay tuned. But right now, the side effects of some of these high statins are sometimes worse than the disease. So I hope that was clear, that high cholesterol is not associated with macular degeneration, at least in 2020.
And Sarah asks about dark adaptometry. How user-friendly is the device for the elderly? She said that they have used artificial intelligence and virtual reality in her office, and those 70 up and that age group seem to have some trouble using that mode of testing. So dark adaptometry, how easy is it for the elderly, which is who most patients will be using it?
Yeah, so that is correct, or at least like if you can do this test on someone that does have a macular degeneration or drusen to see if you can get them timed. Sometimes they're out to 12, 15 minutes. You're trying to see if you can bring down those dark adaptation times, but we're really trying to find to be useful is in these 50 to maybe 60-year-olds that have dark adaptation problems but no visible drusen. So it can be used on a broad spectrum. But hopefully we're going to be using this instrument at a younger age rather than an older age. But the old instrument, what I call the microwave, I agree, kind of a pain in the butt to use. But these new virtual goggles kind of puts them into their own space. You can they don't have to sit up. They can kind of just relax, get comfortable. And the instrument will not move on because it tracks pupils and see if the patient's looking in the right area. And we found that the newer instrument is much more user-friendly for the older patient. So the upgrade in the technology, I agree. The old technology was not very user-friendly. The upgrade is certainly an improvement. It's not foolproof, but it's definitely an improvement. And I think you probably have used the old instrument, so I can tell you that the newer instrument does it much better. So,
Greg, Tara asked if you have a particular UV blocking lens that you recommend to patients. I personally do not.
Yeah, I don't either. You can get really geeky about it. Let me just tell you right now that me staring here at my computer monitor for the last almost 2 hours, I'm not too worried about the blue light coming off my computer monitor. It's more the sunlight that's out there. Blue light coming off my computer monitor does create dry eye. I'm not taking that away. I'm not taking away that there's computer vision issues and fatigue in the ocular surface. I just want to clarify that the blue light coming off my computer screen is not creating macular degeneration. So blue filters, in the office while working on computer screens, I'm not really lowering the chance of macular degeneration. All the other stuff that we talk about and we know as optometrists, I'm not poo-pooing that. I'm just focusing on strict macular degeneration. When you're going out into the sunlight, you just want to make sure you have 100% UV blocking. There is a specific wavelength. I'd have to look it up. It's like 534 nanometers or whatever the wavelength that you could block specifically. And there's some industries out there that really hone in on that because blue light is important, right? Blue light is important for us to wake up and go to sleep, helps with our, emotions. So you don't want to maybe block everything. But, that's really getting down into granular level. The key is if you have a patient that is at risk for macular degeneration, the key is make sure that they're wearing sunglasses when going outside. So I don't really have a specific lens. You can really get granular on that if you want to block that one wavelength that creates that oxidation. And there are some lenses out there. But to me, just make sure you have the patient with some UV coverage.
And our last question is, does chronic use of oral prednisone have any effect on getting AMD?
I am not aware of any association with steroids creating macular degeneration or any of these studies out there that show that outcome. I do know that oral steroids do wreak havoc on the macula. It can create a central serous. So there is some macular stresses out there. Does it particularly create the drusen and the cholesterol buildup and cause macular degeneration? I'm not aware of any studies. Joe, I know you do a ton of writing and read a lot out there. I'll lean on you for that to see if there's any other comments. We do know, again, that steroids can put stress on the macula and that central serous. That's someone comes out central serous, make sure that they're not taking steroids. But I'm not sure of any association with age-related macular degeneration.
And I agree with you. What I will throw out there is with the large soft drusen, there have been theories about a chronic choroidal inflammation that leads to their development, and they lead to more toward breakdown of Brooks membrane. So theoretically, maybe even oral prednisone could be beneficial, but of course, patients can't be on that forever, and that's purely speculative. Yeah, Greg, I'm gonna let you take it back over because we have to be respectful of everybody's time. We had our guest on, and we have to make sure we end right at 9 p.m. Eastern time.
Okay. So we'll keep moving along here. And let me just kind of pick up. We were talking about type 1, type 2. We're going to move into type 3, retinal angiomatosis proliferation. And again, the key to this one is this is type 3. It starts in the retina. It's not originating down here in the choroid. And there's stage 2, there's stage 1, there's stage 2, there's stage 3. You can see here that it's starting, again, in the retina. It starts to grow anteriorly. It can grow posteriorly. It creates this communication. Once it creates this communication to the RPE, it can create a pigment epithelial detachment. That's kind of the difference between stage 1 is that you have the membrane, in a sense, starting in the neurosensory retina. It creates a sensory pigmented epithelial detachment at stage 2. And then when the blood vessels and everything starts to communicate and neovascularization penetrates into this RPE space, that's when it goes to stage 3. Kind of really tricky to kind of pick up. You kind of have to be really good at looking at OCTs to be able to see it. And here's a nice fundus picture of RAP after we know what it looks like and we have the diagnosis. This is what it looks like on a fluorescein angiography. But here's what it classically looks like on a spatial domain, right? Remember, time domain, you're not going to be able to pick up this type of, but here is your RAP lesion. You can see that it has created this neurosensory retinal detachment in a sense. You have the hyperreflective lesion above the RPE, the epithelium. You have the intraretinal cysts. That's kind of what this picture down here is showing of where the stage is. And then you moved into stage 2 where you have the serous pigmented epithelial detachment. Again, it's a little tricky. This is stage 2. This would be a stage 3. Again, you can see the lesion here. You can see the intraretinal cyst. You can see the RPE detachment. And now it's more solid and leaking. You can see what it looks like on the fundus photography. And this is the cartoon picture over here. Again, the lesion being here. You can see the cysts. You can see how it's not black. It's filled up with activity. That means there's some blood being absorbed by that. So this here would be your stage 3 RAP lesion. So again, this is some high advanced, some really cool stuff when you can send it over to the retinologist and they're like, wow, how'd you pick up that you had a RAP lesion? But it's really cool with OCT angiography, the amount of the visualization of this choroidal neovascular membrane that you can do here. John, let me go through type 4. Maybe there might be some comments, and then I can make sure that we do land on time. We'll be like Delta landing on time and giving and respecting everyone with their timing. But type 4 here, again, as Joe was talking about, when it was below the RPE, it really wasn't classic because you couldn't really see it. It wasn't well defined. This would be your occult membrane. Then it would break through and it'd be very well defined. And this would be your type 4 or mixed when you had something that was below the RPE and above the RPE. And again, here it is here showing you in this photograph. You can see here it's the angio is in the deep. You can see it's in the outer and in the choriocapillaris. And we've got a little bit fancy here by using the technology. The green mix here is sub-RPE, and then the yellow would be subretinal. Again, showing the mixed lesion here of this patient. So the OCT angiography, when I do these talks now and I raise the hand, how many of you have an OCT? 80, 70, 80% of the audience raises their hand. And then how many of you have an angiography? Again, it was like it was maybe 10 or 15 years ago. A few people raise it. My comment is now that I've used this technology for about 2.5 years, there's some diseases like macular degeneration and diabetes that are vascular, and I use my OCTA strictly on that. And there's diseases like plaquenil toxicity. Doesn't really do anything to the angiography, and so we want to follow them on the traditional B scan, looking for the atrophy that's occurring to those outer retinal layers in plaquenil toxicity. So if someone said to me, like, which one's more important? Is it a 90 or a 78? Well, I kind of use both of them. I like my 90, it gives me a little wider field. I like my 78, I can pick up macular edema a little bit. I like having both. And it's kind of like right now after doing this, if they told me to pick, I'd be like fighting and screaming, no, I need both. There are some conditions that I want to have the angiography on. There's some conditions I want to have the traditional B scan. So I think as this technology goes and we talk about it more, that an optometrist start embracing it, that they're going to find out like having both in the practice are just as important, because you can see some really cool things that you can do it. But tonight we're highlighting the macular degeneration side. So this subclinical or occult non-exudative, again, in 12 months, 15.2 times greater compared to the eyes that have no subclinical choroidal neovascular membrane. So just pay attention to what's going to happen out there as time goes by, what we're going to do for these patients. Joe, any comments? I know you were going to say you were going to make a wrap comment, or do you want me to move along with the presentation?
I think you should just keep moving along.
Okay, so here's our occult non-exudative choroidal neovascular membrane. This is patient A. I did the angiography on this patient. I saw these bright spots. If you come across here, this little area here concerns me in the outer retina. This little area concerns me right here. And you can see I have the crosshairs through this area. And this is actually the choroidal neovascular membrane. This was my first patient that I picked this up on, sent it over to the retinologist. And this is the membrane that's most likely leaking unless there's another membrane that we're not picking up, creating this fluid over here. This was the patient that we watched, and they did bleed, and then they finally injected the patient. But again, here, as you can see, looking at this, if you look right here, I'm clicked on the choriocapillaris. We're looking at the choriocapillaris, and we're seeing these little buds that are popping up. And when I put the crosshairs through here and come down here, you can see just the amount of activity that's below this. Shoot this on a fluorescein angiography. This is not going to show anything, no leakage, nothing. If you send it to the retinologist, they do nothing, see them back in 2 to 3 months, watch this area closely. You could see how sick this RPE is by amount of hyperfluorescence that's getting into the choroid. And look at this RPE foci right here, this RPE pigment scar, for any lack of a better term, that is a focal hyperreflective lesion. And again, look at this one right here. See this, how I put it through the crosshairs? You can see the amount of activity that is happening here. This is concerning. We can watch these patients a lot closer if the retinologist does not want to do any anti-veg injection. You know, which of these drusen down here is more suspicious? Let's take a look at this. Look at this drusenoid PED. Look at the hyperreflective columns, the hyperreflective foci. Really sick right here. Here's a drusen and here's a drusen. So this is that drusenoid PED, little bit of RPE changes. Which one is scarier? Which is the scariest? And so I'm going to remove this now so you can see it, and I'll blow it up here for you again. Here's what I just showed you. Look right here, no blood flow. This blood flow is concerning right here. Fluorescein or OCT angiography has been really, really fun in the practice. Look at this patient here with this wrap lesion. Check this out right here. Look at the cyst that we were able to catch for this patient, and then we were able to get it off to the retinologist for treatment. Look at this right here. Before. Look down here, a few hyperreflective foci. I've been following these patients closer. Ladies and gentlemen, I'm telling you, I've been being a geek in my practice, following these patients. We caught it this early, and we were able to get the patient an injection, and look, we were able to maintain. Look where this lesion is. Look right here. Everyone look. It's not in the macula. Look over here. Look where this lesion is. See where it is? And we're able to get this patient treated. It was great, and it made me feel good for this patient. So that's the beauty, early detection of these patients. And you can see, just look at how sick. Look down here where I'm rubbing moving my pointer. Look at all this hyper-reflective columns. Look at all these hyper-reflective columns. Look at the fluid, and we're able to pick up these patients quickly and get them off for their treatment. And this patient here, just to kind of show you, we can kind of tell you that it's leaking, but look how beautiful this membrane shows up. Now take a look. It's in the choriocapillaris. It's labeled right here, choriocapillaris, outer retina. This would be what? This is what Joe was saying about. It's classic. It's well defined. This would probably show up pretty well on a fluorescein. We can send this off to the retinologist and get treated very, very quickly, right? And that's the beauty of why we follow them up and catch these. And these patients might even be asymptomatic. They're doing their Amsler grid. Everything looks great. And then I'm feeling pretty good because the history is revealing, oh, maybe I can let my guard down. Whoops. Nope. Can't let the guard down, but glad you're here. We're getting you over to the retinologist and get this classic choroidal neovascular membrane treated. With that being said, there's treatments out there. Early detection is very powerful and meaningful. What can we do? We kind of talked about this. Prescribed smoking cessation programs. Remember, smoking depletes serum oxidants. It decreases pigmentary density. It increases the risk to advanced macular degeneration. Beg, plead, get them into smoking cessation programs. We know that smoking is bad to begin with. Smoking is bad with anyone that has macular degeneration. If you want to have some fancy reasons why, here it is. Depletes serum antioxidants. It decreases pigmentary density. And it's been shown multiple times to increase the risk. Lifestyle and diet, lifestyle changes, diet and exercise. This was kind of something that struck me. You guys know I lecture with a pharmacist from time to time. About 2 years ago, we were talking about vitamins and all these different vitamins. And she just looked at me and she said, Greg, do you realize it's better to get vitamin A, C, E, zinc, copper, all these different vitamins that are out there from natural food sources rather than giving someone a pill? That really hit me hard. So that's why we always stress lifestyle changes. It is better to get these nutrients that we need from eating spinach. And we understand that sometimes these vitamin companies say, you have to eat 20 bowls of spinach to get what's in this pill. But it's also important to say to the patient, look, it's also just as important to get these vitamin supplements from natural sources rather than taking a pill. And then if they don't want to really change their diet and exercise, then we're kind of spitting into the wind. So exercise is important. There's some studies out there showing that if someone walks 1 block and back a block, that it decreases the chance of a choroidal neovascular membrane. So it's not like you have to join some fitness club or just, or do insanity or some crazy workout. Just a little bit of walking decreases. So that's the lifestyle changes, diet and exercise. Get some of these vitamins and minerals from natural sources rather than vitamins. Controlling systemic diseases, diabetes, obesity, high cholesterol, oxidative stress. Those are the diseases that out there that create oxidative stress. Nutritional supplements, with the subclinical and substructural, that's where there is some controversy out there. But I'm going to tell you right now, just do something. Do you need to be doing AREDs? The answer is no, probably not. That's not where the science is right now. But it might change. I treat just like a glaucoma suspect. If someone comes in and they're high risk ocular hypertension, strong family history, thin cornea, so on and so forth, and I say we're going to treat you, we treat you, right? So there are some subclinical, substructural with a strong macular degeneration. I put them on AREDs. There are some out there that just get over that 6.5 minute sign. Maybe not a strong family history, but there is a history out there and they're concerned. Okay, I'll use lutein, zeaxanthin, and maybe mesozeaxanthin, that triple carotenoid or the double carotenoid. I'm the doc. I try and work with the patient. I don't paint with a broad brush. But if I have enough experience, subclinical, substructural AMD, I'm doing some type of vitamin supplement. Intermediate to advanced, no brainer to do AREDs. So that's kind of where that all is out there. So we can remember, smoking, lifestyle changes, diet, exercise, manage the systemic diseases, do some type of nutritional supplements. Don't forget, you can do sunlight protection. We talked about that. UV protection, closer follow-up. That is a treatment, right? We know I follow these patients now that I feel more comfortable interpreting an OCT, looking for those changes, trying to do modified lifestyles, getting them on some supplements. I follow them a little bit closer, and then don't forget low vision and vision rehab is another way to treat patients, especially on that unfortunate, that kind of that low vision spectrum, that 2200, 2080, 2400, that low vision range. It doesn't have to be that bad. Even 2060, if they're struggling, get them a low vision consult. With that being said, I wanted to talk about the treatments of choroidal neovascular membranes that are out there. We have the anti-VEGF. These are biologics. There's a lot of cool biologics out there that we can talk about, but it all started in the eye back in the day with the, where is it? Avastin, right here at the top, with Avastin, and that's a humanized monoclonal antibody. And then there's Lucentis, and you can see Lucentis could be used for diabetic edema and retinopathy and retinal vein occlusions. And then Eylea, again, approved beyond macular degeneration to diabetic macular edema and retinopathy. And they're a little bit different. This is a humanized monoclonal antibody. These are all biologics. They're a full antibody, where this is more of an infusion protein. All again at targeting that vasoendothelial growth factor, targeting it and putting it to rest to say stop growing blood vessels. And Macugen, not really well used. That's why I put it down here at the bottom. Not that well, not that potent compared to, Avastin, Lucentis, and Eylea. And then this one has now entered the market. Really, really cool change in the biologic. It's a humanized single chain antibody fragment. And what that has done, it's targeting a different structure on that vasoendothelial growth factor. And in some cases, you're getting up to 3 months of dosing. Most are 4 to 6 weeks, but you're getting out to 3, as opposed with maybe some of these where you have to give them a shorter, so less injections into the eye. And that one's Beovu that's out there. But again, all of these, when you see these, well, the MAB stands for monoclonal antibody. So these UMABs, there's a UMAB. This one is not a UMAB because it's not a monoclonal antibody. It's a fusion protein. But again, here it's a UMAB because it is a human antibody fragment. Really cool stuff, but I just wanted to touch about these different injections that are out there and how they're kind of using biologics. And those, if you remember, are using some type of virus or antibody or bacteria to grow this antibody, and then they twist it up, and then they're usually injected out there. So they're just really big molecules, but cool molecules, but they're all anti-VEGF targeted, just picking on that in a different way to kind of make it, lack of a better term, inactive and taking away that signaling. So with that being said, I know we're getting close here, Joe. Here's how we started off with Chad with the loss of his foveal pit. Everyone out there, look, that's been paying attention. You see this here? Hyperreflective foci, or I'm sorry, hyperreflective column. A little bit of a column. Look at these columns. 1, 2, 3, 4. Monitor, monitor, monitor. Oh, this really makes like nails on a chalkboard to me. Again, monitor, monitor, monitor. Here was my reply right here. Look at this long drawn out chalk. You know, I talked about the epiretinal membrane, and you only showed me 4 OCTs, but I do see some hyperreflective columns. We could do more for this patient other than monitor. If they're a smoker, we can tell them to quit smoking. We can work on this patient's diet and exercise, right? It's better to get the nutrients. You know, if they're eating McDonald's every day, come on, let's try and change this up. Can you walk a little bit for me? Can you do something for me? This is going to help out these hyperreflective columns. This RPE is sicker than we think. We can do some type of vitamin supplement. You decide what you want to do. Let's look at their systemic health. Are they diabetic, cholesterol, have any obesity? Let's treat those oxidative. Can you wear some sunglasses in any ultraviolet light? Again, getting back to the supplements, you could do AREDs, or you could at least do a triple carotenoid, or at least talk to them about lutein, zeaxanthin, and miozeaxanthin. So there was a little bit more that we could do for this patient other than monitor, monitor, and monitor. And I was hoping that someone on these on Facebook would take that to heart. Joe, this is our last polling question. Can you launch that for me, please?
I will.
And as you're doing that, regarding age-related macular degeneration, I am better prepared to help prevent vision loss. I am better prepared to detect progression. I am better prepared to know how to find AMD earlier. All the above, or AMD causes vision loss and we can't do anything to help it.
I'm going to end the poll early because I like what I see. Wow, we're 100% at all the above. We just dropped off, but yes, all
Perfect.
the above.
So good. So that's what I was hoping. I hope we were able to move some people out here. Everyone always asks me for resources. OCT Connect is something that I have no financial interest. It's Julie Rodman and I being a geek. It's on Facebook. It's called OCT Connect. It's up to about 6,000 people. You just go in and drop OCTs in there, and you get some answers in there. Julie polices it a little bit more than I do, but there's enough people in there that it's kind of going on its own, and a great resource out there. Another one, anytime you see these guys' names over here, Goldman, Wahid, and Duker, yeah, that's just a great retinal atlas when you're looking for the B scan. Julie is a friend of mine, and she did write a nice book out here. I have no financial interest in it, but she has one on angiography. So one on B scan, one on OCT angiography. Those are the resources. Again, I have no financial interest in any of these books here, but people always ask me. So those are the resources if you want them, right there. With that being said, Joe, any final questions?
There are no final questions that I can see. Thank you all for joining us for AMD A to OCT to RI to Z, what you need to know with Dr. Greg Caldwell. If you're interested in upcoming webinars and enduring learning, visit our website at www.optometricedu.com.
So there it is. There, I have it up on there. There's some other, there's the slide. There's our web address down there. And then I'm just going to complete this, Joe, with some housekeeping. Again, everyone, this course was recorded. A replay will be sent tomorrow. I will have it uploaded to our YouTube channel because that replay will expire in about 2 weeks and you won't have access to it. But if you just go to Optometric Education Consultants, it will be housed there. Important, you probably have already received the email tonight. If not, it will be happening here very shortly. You'll get have a survey in it. Please either fill it out tonight or tomorrow. We need that for the regulatory process. And again, Vanessa is our conference administrator. Everyone, please pay attention because I get tons of emails on this. I will verify everyone was here tonight, be the polling questions, and by the time they logged on, logged off. I'll get that information to Vanessa. She'll give it to Arbo. But Arbo is 7 to 10 days behind. So please give them the courtesy because there's a lot of webinars going on. Also, Vanessa will email you a certificate probably by the end of this week that you took this course. With that being said, I think that concludes it. I'll thank everyone. Thanks for listening tonight. Thanks for attending. Joe, final comments?
No, I want to thank you, Greg, for putting that excellent AMD lecture on. We have a lot of good comments. People seem to really enjoy it. People seem to have now become accustomed to meeting with us on Sunday nights and Tuesday nights, and we'll probably be keeping it on those. We may add a few other days in there. But at this point in time, please be safe. We're happy that we can help you get your education and in a safe way. So with that, be safe, and we look forward to seeing you live soon.
Bye-bye, everyone.